Okay, well we'll run through a number of things, if I can press this in the right way. So what we're trying to do is link with somebody our strategic objectives as an organisation. So at the top of each of the slides is the high level strategic objective, and then how are we doing. So we want it to be the best trust in the Northwest for patient, customer and staff satisfaction. Measure around that. What you can see is really continued excellent work in our emergency department, but we've got work to do elsewhere where we're seeing a slight slip on our inpatient promoter, and we really want to be above 70, and we're down at 64. And I think from memory from the strategic reviews that we had with all the divisions on Tuesday was that I think surgery are in a better position, and I think there's work to do in medicine on the inpatient side. And we do know that the better the response we get, i.e. the more people we ask, the better our friends and family score is. So again, it's just to encourage everybody to focus on making sure that we get those forms completed and get our response rate up, because in some areas we've the response rate is really, really low, and that distorts the figures and tends to be to our disadvantage. So again, if we can just try and make sure, particularly I know some areas where there's rapid turnover of patients, sometimes they're out and away before, but actually they're probably the patients that would actually give us a more positive response that says actually I'm in, I'm out, and I'm appreciative of what happened to me. So if we can just push on that. And the score will change slightly in November, but the same principles apply really. Staff survey, and I've had a number of asked the chief execs about, why are we wasting money on staff surveys when money's tight and forms and things. Well, actually this is a national thing. It's an NHS thing of which we have no real control over. I know what we try and do is a number of more limited pulse checks that says, look, just how is it going in your part of the organisation. But the staff survey is something that every organisation needs to complete. And that's just an update, so please make sure that we do complete the surveys, because the more comprehensive the response, then obviously the more valid it is, and therefore we can deal with anything that comes out of that. And certainly we know from previous work that we've picked up and we've understood those themes, and I know some of the things that came out of previous surveys, for example, has found their way to the LIA leadership group, the sponsorship group, and working through what can we do to positively influence some of those things. Infection prevention and control, we know this has been a big issue in terms of the emerging new infections, CPE, VRE, and then obviously we've got the C. difficile and the MRSA. We're doing a lot of work. Jill and the team are doing a lot of work, supported by Terry Whaley, on the rapid testing, trying to make sure that the sooner we know about it, because in the past we've been wise after the event and we can track where we've moved a patient across the hospital and the impact that's had. Now we're starting to be able to have the ability to pick up those people much more quickly, and that's good, and do something about it. But there's a lot of work still to be done there. C. difficile I'm really disappointed about. We had a bad start, but to the year where very quickly we got 7. And that was because we hadn't got the HPV programme working again for various reasons. We believed that by getting the HPV programme up and running, that would make a huge difference. And it did, and we were stable for a while, but actually bit by bit we've crept up and against our target. So at 15, I'm going to have to report that to Monitor now this month, because of the tight Monitor controls around trajectory. Because we're over trajectory, it's still not, we can bring that in on target, and I think the target is 24.
Yeah.
So, but we're only halfway through the year, and we all know that the second half of the year over the winter you would expect to be worse than the first half of the year. So we've really got to work that through, but there are some very tight controls about what you have to report to Monitor. So that's not good, and I'm being advised that that's not going to be a good thing for us to have to do. So again, it's back to, and I know Jill's issued a lot of information about the need to get really control the basics and hand washing in particular. So again, it's just a plea to try and do all the right things there, because that's the baseline, as we've said before. If there is, let's be safe, and then there's good clinical outcomes, and then there's the patient experience, well, as a minimum, we absolutely must get the safety bit right. People don't come into hospital to be hurt, and therefore good infection control is a really important part of what we do. The flu vaccination I've just talked about, we know that this is again seen as a key national measure. One of the things that happened last year was that any additional income and additional monies that trusts were able to draw down in a variety of ways potentially was linked to you have to be at least 75% on your vaccination for flu. So it's something in that regard, and that was used as a blunt instrument because the Department of Health and the NHS believe that it's a really important thing for everybody to be vaccinated, because they can't afford for healthcare workers not to be here and providing that healthcare. And obviously the last thing I want and you want is to be ill yourself. So it's really a big push to say, can we make sure that everybody gets vaccinated? And we did really, really well last year, and we need to repeat that this year. On workforce, we've done a lot of good work on appraisals to get those up. Obviously, it's not only having the appraisal, we're making sure that actually it's a worthwhile exercise as well. We've slipped a little bit, remains below the target of 88%, but it's still quite good at just over 82%. But again, I know that's an area that people are pushing. And there'll be a range of things happening, and we're trying to identify where people haven't had their appraisals and try and push that forward. Listening into action, there's a lot of things going on. We had we've got the Pass It On event on the 5th of December. I have to say I've gone to all of the Pass It On events, and I know it's difficult for people always to attend, and the people who do attend broadly are there because they are presenting. But it is one of the better times that I spend when you go and you listen to the work that colleagues have done in their area. And a lot of it isn't visible unless you go there, but it really is very worthwhile, and a lot of good work that we're doing behind the scenes, if you like, in different departments in different areas. So I would commend that to you. We are looking to have a number of big conversations, particularly again with managers and leaders at all levels in the organisation, because we know how challenging it is in the NHS. And it is interesting, the Foundation Trust Network have written to all of the key politicians, either in government or in shadow form, and have written some really excellent letters describing the issue in the NHS at the moment, and particularly for acute trusts who are feeling the issue more than anybody else, about saying you're seeing a situation where financially it's getting ever more difficult for foundation trusts generally, and particularly the acute sector, the hospital sector. But at the same time, there's all the drivers for quality, the KEO pressures, the pressures to put additional staffing on wards, the pressures on all sorts of things to raise standards and to put more resources in place, at the same time as to dramatically cut costs in a way that the NHS has never experienced. And basically what they're saying is, unless somebody does something, then really the system is abdicating responsibility purely to providers, that we're left just to try and make a broken system work. And that's an incredibly stressful and difficult place for us to be. But that's the reality of where we find ourselves. And the public, and we all want to provide a really good service, but it's under increasingly difficult circumstances, and we appreciate that. And therefore, we want to have a number of big conversations, managing leaders, say, how do we try and do that? Because that's really difficult. If we don't hit the finances, then it has inevitable major issues where you simply, if you spend more than you earn, you eventually run out of cash. And we can't afford to do that. And on the other hand, we want to provide the highest quality, best possible service. And it's thinking about ways in which we can do the high quality thing, but also do it within the resources that we have available. And remember, we still spend £800,000 a day, and it's how do we spend that most wisely to get the best possible outcomes. But I think having those conversations will be helpful to say, you know, it's not that we don't appreciate how difficult this is, but how can we do things in a joined up way together. So, and then elements, the HSJ shortlist, the HSJ, the Health Service Journal, really is the magazine that's read by the vast majority of people in healthcare in one form or another, and therefore the Health Service Journal Awards are really the highest profile awards, and we have been shortlisted, and I think the presentation that myself and Sarah Pickstock and Cathy McEwen, supported by Ben Capel, that did was very, very well received. Of all the work that we've done in terms of raising standards about engagement, about our values, about first impressions, about all the things that we've tried to do to make the organisation live and breathe the values of the NHS Constitution, if you like, was really, really well received. So I'm optimistic. You never know, but we might well win that national award, so that would be good. And then the staff Christmas party, 29th of November. Really importantly, Cerner, the Wirral Millennium Phase 2B, as I've said before, we really now are getting to that tipping point where with Phase 2B going live in November, which means that we switch off PCIS, that we do all the meds management, it has a big impact across the whole organisation in terms of nursing, documentation, in terms of we administer medicines. So it's a real big push to say we're going live on the 15th of November. Everybody needs to make sure that they're fully involved in the training and that we're in a really good place for that. Jerry?
So we just add a 0 after the 45 iPads because it's 450.
So yeah, 450 iPads. Well, I hope after 3 or 4 weeks we've still got 450 and it's not 45. I'm sure Mark's got a clever way of ensuring that that's the case.
We have.
Right, good. For God's sake, don't take them, because they won't work if you take them, and then you can't bring them back. So yes, really important, but we are getting to that tipping point because we've got to use the technology, because we've invested over many, many years, and I know it's been difficult because a lot of that has been that slow burn, but we're now getting to that point where it really is going to affect virtually everybody in the organisation about how we use the technology and how we exploit it. And it's back to, it has to be one of the things that allows us. We've got to say, we've invested very heavily in this. We've got to make it work. It cannot sit to one side. It's got to be part of our key armoury by which we do that high quality service for less. Because otherwise we can't rewrite history and say, come on, we'll do something else. So we've got to make this work. And there's no doubt that when we've gone out and benchmarked, there's no doubt that Cerner functionality nationally is best value for money compared to any of the other schemes that we looked at. So in terms of where we are on the finances for month 6 position, and this gets kind of slightly complicated, but in general terms, what we did was to, if you remember, we said we don't have plans, we don't know how we're going to do all the CIP we need to do by the tune of about 4 million, and therefore each month, at the moment, you've got the thick end of sort of 400,000 that we don't know how we're going to deliver that CIP. And that was put into the plans that says, well, we'll be 400,000 down, but we're going to have to close that gap. Well, the good news is that roughly, the planned deficit of 356, well, we can't afford to end up with a deficit, but that was to say, knowing what we know, we need to hit that. And the good news is that we ended up with a deficit of 368. So against the plan, we were more or less on plan. But that still means we still need to close that gap on regards to the CIP that we need to deliver. But so what that meant was, you'll recall that by the end of the year, we've got to make sure we don't lose more than £4.2 million. So that's still a big loss, but that's what we've planned to do, is to make a reasonably large loss, but hopefully a lesser loss next year. At the moment, the plan was to essentially, in the first 6 months, lose the 4.2 million, and in the second half, and I'm oversimplifying this, but in the second half to break even. So at the end of the year, we end up at 4.2 million loss. Well, we were at we were planned to be 4.5, and we're at 5.2 now, because just bit by bit each month we've been just a bit over. So what we now need to do is, with sitting at 5.1 million deficit, we've now got to get that back to 4.2 and then run. Now the good thing is that was, and you'll think, well, that doesn't make sense, but you don't have all the CIP schemes fully active and working in the first half of the year. It takes time, so there's always a bit of an S-curve, as they call it, where things take time to build up the savings. So you always backload some of the savings, although it's nice to have them at the front if you can get them. But what it does mean is we've got a real challenge now as to how do we deliver the initial plan, which was to break even for the rest of the year, because we won't spend as much, because we'll have all the CIP schemes that we've collectively worked on for a year or so, because we were planning for some of this last year to impact on this year and all the schemes for this year. But we need to claw back the over expenditure as well. So there's an awful lot that we need to do there, and there's a lot of pressure on Monitor, and we're on monthly monitoring from Monitor, where we have the joy of a call, and I think we've got that later today, where they will go through this line by line with us as to what are we doing to turn this around. So so it could have been worse. We could have had a bad month. We had a month that was broadly on track, but we've got one hell of an amount to do between now and the end of the year. The other thing is that we had a reasonably decent month because the activity was complemented by all the 18-week RTT work. You'll have heard and maybe seen in the press things about how the government were investing in additional monies to bring waiting times down. Well, we were already 18-week compliant, but many organisations weren't. So we've bid for and got additional income to do additional work, which effectively was looking to bring our waiting list from 18 weeks to about 16 weeks. That's what that was about, and that we got extra monies in to do that. We obviously had to spend some of that money in order to see those patients, but that helped enormously. That's not going to be available to us for the rest of the year, so we really need to deliver on the activity. And there's a real pressure, particularly on the surgical division, in order to make sure that we deliver the activity. Because if we all work really hard to deliver all of the savings on CIP and everything else, that's still is predicated on us delivering all of the activity. There's no point in us delivering all the savings and not having the income coming in as well, so we absolutely need to do that. And the only good thing about it is we only get income by seeing patients. So it's really good to see more patients and deal with them, and they'll be happier and we'll be happier because we get the income. So that's the real challenge, is we're going to have to up our productivity and up the activity for the rest of this year. I see a number of people looking at Pam Yanis, and I don't know if everybody knows Pam, but Pam is the acting ADO for surgery. So she's got a big challenge on our hands, along with the rest of the team. The cause rating is really principally about liquidity and cash, and we are now a cause rating of 2 again, which is good, because we were a cause rating of 1 in August, and that is absolutely not where we want to be. But again, the reason we're in a cause rating of 2 is because we're selling a building and we've got a £7 million loan. It's the £7 million loan that's allowed us to be a cause rating of 2. But of course the only unfortunate thing about loans is you have to pay them back. And also, as I say, we are selling a building to CWP, the Cheshire and Wirral Partnership, which is Springview on the right hand side at Clatterbridge. But again, it's not where as an organisation we would want to be, where the reason that we've got cash and the reason that we're able to keep moving forward is not because we're earning more than we're spending. It's because we're selling buildings and we're borrowing, and that's not going to be sustainable. So we need to get to a point where our cost base comes down and our income remains at its level or gets better. And therefore that's why we've really got to put so much effort into all the CIP schemes. Nobody wants to do these difficult things. I know they're all really difficult, but they're absolutely necessary if we're going to sustain as an organisation, because there aren't many more buildings we can sell, and we're not going to be able to get another loan. So we're buying ourselves time to do the right things. It's only about buying ourselves a little bit of time so that our fundamental cost base has to come down. So that's what we've got to do. And therefore you see that our cash balance, Monitor were really worried when we were predicting our cash balance about being 3.9 million, because our monthly wage bill is over 17 million. So that's what, a fifth of a month. So that's what, six. So we had about 6 days worth of cash in the bank, which is why Monitor were so worried. Now we've done a load of work, Alistair and the finance team have done a load of work to make sure that we get paid earlier and we don't pay other people a bit later and all of that. And obviously the loan has helped, the receipt of the loan and all of those things that have given up. But that cash balance will come down quickly. That's at a peak. That will be coming down as we spend money, and therefore we've really, as I say, we've only bought ourselves a little bit of time. So the big area is pay. There's no doubt. Whilst we're looking at everything, we're looking at non-pay and looking at what can we do with the equipment we buy, making sure we only essential spend only. So we've said to estates, for example, and everybody else, don't spend it unless we absolutely have to. And even if we absolutely have to, can we delay it? That's where we are as an organisation. But the biggest spend, the biggest issue is pay. And you can see there, 17.4 million. Well, that's against a planned pay expenditure of 16.9. So again, we've got to get that pay bill down. So that's why there's enormous emphasis on particularly trying to avoid locum spend, trying to avoid agency spend, expensive spend where possible, and trying to, wherever possible, not open additional capacity, because additional capacity needs to be resourced. That usually brings around quality issues of one form or another, unless it's done in a really controlled way, and it creates an enormous financial pressure as well. So again, we really want to avoid opening additional capacity at all costs for quality reasons and for financial reasons. But again, I know that the demands are there for patients, and we're desperately talking. I spent all afternoon with the commissioners yesterday about what are they doing, what are the systems that they're putting in, where are adult and social services from the local authority, what are everybody doing to try and tackle the demand. Because the only way we can really have less capacity is if the demand goes down, recognising that there are things that we can do internally, but they need to play their full part as well, and there's a lot of pressure on them to do that. So just put up some things. The PMO is the Project Management Office that Anne Lucas is the head of, that tries to hold the ring on all of our savings plans. And just put up some things there, because really there probably isn't a single part of the organisation that isn't affected by this in some way. And to be honest, if there was, I'd be asking why, because we're not in the fortunate position of being able to choose where it says, well, we've got a whole load of schemes and we need to save a bit of money, so which one of those schemes are we going to do? Because you do the things that had the least impact on people and were easier and all those things. But the reality is that if we did everything we can think of, it still isn't enough. So we're having to do everything and think of other things as well. That's why Monitor said we needed some external support to try and help do that. So we're working with FTI Atkins on that as well. And there's no doubt they've brought about some additional rigour and pace and challenge to that whole process. So we're having to do a lot of really difficult things, I know it, and I've just put some stuff up there, and it's mainly, as well as doing everything else, we're putting a lot of pressure on Mark, for example, to say, how can we use Cerner, how can we drive, it's all very well that we do things better and all the rest of it, but where's the cashable benefits? What can we actually save money on by implementing Cerner and other IT-enabled things? So we're just saying everything from telephony to kiosks to Cerner, all of those things we're looking at the non-pay expenditure on supplies and drugs. And again, we've had some very good meetings with PIPA about where can pharmacy play their part, and although they've got a lot of really good schemes on trying to reduce the costs, because again, that not only on a staffing sense, but our pay on the staff, the drugs bill is enormous, and therefore again trying to ensure that we save money on that drugs bill as much as we possibly can. But then we're looking at everything else as well, and I know that's really difficult and it's unpopular, but we haven't got any option when over 70% of our costs are staff. We just have to look at everything. And then the key thing about how can we do something that's good for patients and good for the finances is about that capacity. And if our length of stay can come down, then obviously we can see more patients within our capacity, and that means we don't open other beds and other capacity in a way that puts pressure on nursing staff and on other staff, and it has quality implications as well. So patient flow and length of stay is really critical. And as I say, I really wish the cavalry was coming. I wish I had any real confidence in any of the political parties to really understand this. But this is a really difficult issue, to be fair to them, that they're really struggling. I think there is a growing recognition about how challenging the health service is at the moment and the pressures that are being put on all of us. But I don't really think they've got many answers, or the answers that I saw on the television this morning are just playing around the edges, or the fact that we're going to try and help people in social isolation by communities being more helpful towards aged people and all that. That's really laudable and it's a good thing to do, but is it really the big strategic answers that are going to deliver change in the short term? I don't think so. So there's some real challenges there, and it's going to be more and more down to us as to how do we do that and how do we respond. So it is a real challenge. So we're at 5.1 million deficit against a plan of 4.5, and we need to get it down to 4.2. Cause rating of 2, fine. Income was supplemented by some of the other things that I've talked about there. Without that, we would have been below plan, and as I say, it's really down to as well as everybody doing their bit, I think it's principally surgery's got to deliver on activity. And those are some of the things that we need to do, but I think I've covered those. In terms of our performance, we had a strategic review with all of the divisions on Tuesday, and I have to say it's a difficult time for everybody, and I think everybody's struggling to one form or another. But I came out of the divisional reviews feeling better than I've done for weeks. Because I thought the performance of all of the divisions, talking about what they were trying to do, strategically what they were delivering, the various things that they were doing to make their part of the hospital better in terms of clinical outcomes, in terms of efficiency, in terms of reshaping what they do, it was really impressive. And overall, we were really, really pleased with the quality of the work that everybody has done. So it does give us confidence we are doing the right things, but I recognise on a day-by-day basis it's a hard slog. But when you step back each quarter and look at what we're achieving, it really is very impressive, and therefore a big thank you to everybody for that. And things are definitely getting better in the sense that we know that the A&E target has got incredible profile nationally, and that was something where we were struggling as an economy and as a hospital, but we did deliver 94%. I think we did it by one patient for quarter 2. That was really important though, because on our trajectory of improvement, we had said to Monitor that as an economy we'd be at 94% for that quarter, so that was really important that we achieved that. But then in the last 5 weeks, we've had really good performance there, and a big thank you to everybody that's contributed to that, because it's fewer and fewer of the issues are around ED. Yes, there's things going on, but there's a lot of good work going on there. What we need to make sure is that the whole hospital is working properly to get the flow right, and that we resolve this patient flow in beds. But there's no doubt that our A&E performance has got much better, and if we can keep that going, that will make an enormous difference as to how we're perceived as an organisation. We might be perceived as an organisation that's got financial challenges and we're trying to do all the right things on that front, but that we're achieving the other things. What we don't want is people joining up lots of dots and saying, well, you're failing on that, and you're failing on that, and you're failing on that, because that would be unfair, because I think we're much better than that. Cancer targets, I think overall we're fine in terms of our combined performance, but we didn't achieve the 2-week referral appointment for breast symptoms and the 31-day for subsequent surgery, so I'm assuming that all the right things are happening, looking at Sharon to make sure that that's being addressed. Say referral to treatment, the 18 weeks, I think overall we've done a good job. We always recognised if you want to get some of the people who've waited a long time through, that's going to have a detrimental impact on your performance. So this is a completely planned situation, and we've done what we set out to do, and again that's been a really good thing. Good for patients, good for us. So BBC coming to a trust. I'm sure lots of people will want to get up at 5:30 on Sunday morning and find their way here, but I suppose it's part of the benefit of the BBC being based in Salford and our growing relationship. The comms team have done a really good job in building those relationships with the BBC.
I'm so sorry to interrupt, but I've got an urgent message for Susan James. This is Susan James, please. So sorry to interrupt.
Okay. So we have a growing relationship with the BBC, which is very positive. Radio 2 are coming. I'm hoping everybody's got the details of that. If not, I'm sure Barbara and Mike and Ben can give further details about it. But also, as well as Radio 2 being here, and that will be live from here. And I think what you're saying is people need to be seated by 6:30. Yeah, on Sunday morning. But also the BBC will be having their Sunday morning live programme with Shan Williams, and that will be based back in the studio as I understand it, but what they will be doing is cutting to a live outside broadcast, if you like, and that will be in our main reception here at Arrow Park. So again, I think that's good profile for us as an organisation. So again, I don't know if there's anything else we need to say on that. I think it's been hopefully well broadcast to everybody, so if you want to, I was going to say get your party frock on, but at 6:30 on a Sunday morning, unless you're still out from the Saturday night, then and if you are still out from the Saturday night, maybe you should do that in the morning. You can catch up with it later. Right, okay. So, I know that's been a quick rattle through a range of things. Is there anything, colleagues, anything, Jill?
I thought the audience might just want to know where we were with CQC in terms of feedback
Yes.
and what we were going to do next.
Yep, okay. Well, I could do it, but do you want to do it? Changes.
I'm sure everybody's wondering where we are with the CQC inspection. It was on the 15th and 16th of September. This was a responsive inspection as a result of concerns raised by staff and also by some patients. And there had been some rumblings for a few months, and we were writing letters backwards and forwards to the CQC. So to be fair to them as an inspection body, they were keen to come in and see for themselves. From my point of view, there was mixed feedback in the report, and we're just going through that at the moment for factual accuracy, and that needs to go back next week. In terms of the good things, I think A&E performed really well in the report overall, very, very positive. So that was really good. The area that we've been struggling with the last time CQC came in, which was Ward 14 Urology, now on Ward 20, also did really well, and that demonstrated really good improvement. There were, however, quite a few lapses in care, which are really disappointing that CQC saw and are concerned about. So as a result of that, we've got minor and moderate non-compliance in areas such as patient safety, privacy and dignity, etc. So we're just going through that report now. What's clear to me, and a theme with what David said today, is we're facing a really complex agenda. I think, for me, I feel almost like schizophrenic, but in 3 bits. you're looking at the finance, we've been concentrating on A&E, we've had the infection problems to tackle, and I just wonder in all of that whether we've had the right focus on some of the basics that we've been trying so hard to get right. That said, I want to leave you with a positive flavour, because the stuff that I report on the whole is going in the right direction, and I think we also need to see the CQC as a slice. It's what they saw on those 2 days on certain areas, and there were still good things in those areas, so we need to be just mindful of how important it is all of the time to be doing all the right things. And if I could just leave you with one message that came out loud and clear from the CQC: if it isn't documented, it didn't happen. And I know that's gloomy, and we all know that, don't we? So it's really just focusing in on that, particularly for ward sisters in the audience, because I know you're all working really hard, but making sure your staff are documenting the great care they're giving. Because if it isn't written down, then the CQC believe it's not given, and so would a court of law, to be fair. We all know this. So document, please. Thank you.
Yeah, thanks, Jill. And it was right to emphasise that.
Yeah.
I know it's really really busy, but as soon as you're under any sort of spotlight, it's documentation. So you're absolutely right on that. Sian?
Yeah, just want to say that we had a JAG visit yesterday, which to the endoscopy department, and although we don't have the formal result for a couple of weeks till it goes to QA, we have been recommended that we'll pass. And the assessors were quite gloomy in the morning, and certainly our hearts sunk when they said basically don't be expecting a pass. Very few people get a pass, most people get a deferral. And at the end of the day, his face changed and he was beaming and said that he's never recommended a pass and an organisation hasn't passed. And I think we should just congratulate Bev Oates and team for the massive amount of work.
That was an excellent piece of work. And I think the board and the executive will get a bit of a amount of work that has to go into achieving that and then maintaining it as well. But again, I think you're absolutely right. It's been a fabulous achievement. It's again an endorsement of the quality of what we do, and a big thank you to Bev and the team for that. I think that's excellent.
Just a couple of minor points on the content of the presentation. Staff survey response rate for corporate services is 20%. Not 20%. You might think there was lots of CIP there, but it was over a lot of stuff. The other thing is, if there are any undeliverable surveys, can you please get them back to the listener interaction office and we'll arrange for them to get to people. And also we're hearing some pockets of staff in the organisation saying there are boxes of staff surveys not been handed out. Can we make sure they get out to the staff that should be out in the departments? The other thing around appraisals, we have got a concern that because of the number of staff in the amber category, as well as the small number of notifications that have come in so far, we're likely to drop again in terms of compliance in this month.
Okay, thanks, Kathy. So areas to focus on. Thanks, Kathy. Paul?
I just wanted a clarity for people that afterwards is just you mentioned about £17.5 million in bank, pay bill of 17 odd million, and there was a top up by a loan and a sale, and that's Aiken's going to drop. And the concern that there was about pay bill, how it was phrased about, are we saying that in the next month or 2 months that there isn't really enough money in bank to pay for themselves?
Okay, no, that's good. Yeah, no, thankfully not in the, because we've got the loan and because we intend to complete the sale of the building over the next month or so, then that gives us the cash to keep going. It's only buying us time to get the rest of the organisation's costs down. And therefore, certainly financially, we will have enough cash to ensure that for the rest of this financial year, we can pay the salaries. The problem is we can't continue to do that. So as we go into next year, unless we bring that 17.5 million down to 16 something, then we will start to run out of cash at some point as next year progresses. But what we've got to hope is that there's a whole range of things happen that we do and other things do to avoid that situation. But people don't need to panic now that they're not going to get paid in the next couple of months. We're okay through to the end of the year, as I say, it's into next year. But I am worried that unless we start doing all the right things now, well, you can't afford to wait until you run out of money before you do something about it. But yes, it's right that people shouldn't be concerned about pay right now. What we should all be concerned about is how are we going to get that pay bill down in the right way, ideally through not using expensive resource but using our own resource as wisely as possible. Debbie.
In this event, well, it's good and bad, the pay bill will come down. Therapy posts, nursing posts are going in for posts because of the problems with short-term contracts and not being able to go empty posts. So the CIP might be met in that way, but I'm worried how we're going to continue to deliver increased activity with empty posts across disciplines. I'm just wondering what the plan is.
Because I think there's still a lot of recruitment going on, but I do know that there is a lot of recruitment going on, but there's no doubt that the problem is that nationally there's an issue because, of course, the pressure to meet an increasing demand and to address the KEO review with extra nurses on wards and everything is something that's leading to a real issue, because you've got a disconnect where I think the latest information I saw that is that we're going to have 500,000 difference within the next 10 years within the demand for nursing staff and the availability of nursing staff, because there's a mismatch now between what everybody's demanding and the available, suitably skilled and trained and experienced staff. So it is a strategic issue, as and the NHS. Jill?
We've been lucky that I've always advised the board that we will get to a point where it will be difficult to recruit nurses. At the moment, I think it'd be fair to say from the sisters and the matrons, we're having people turning up for interview, but they're not matching our values. And I think I would support that wholeheartedly. We know in the past when we've recruited into like anybody will do sort of situation, you end up really regretting that and having loads of disciplinary issues and patient safety breaches. So it is a struggle just at the moment. I think with plan changes to ward and bed bases, there will be then an influx of nurses from when we make the next bed changes. But we need to do that and not keep other beds open. So we need to just hold firm on that. And myself and Tracy, again, are going out on a strategy of over-recruitment into the next March qualification set from the School of Nursing. So I'm holding fire on that. We are ready to go out to overseas, but again, listening to the news today, I think that is not a solution. I think we do need to be looking at the staff that we've got. And I know it's not popular with all the staffing reviews. I know that that's a lot of pressure. But the way I try to rationalise it is it's about moving nurses from where we maybe could do other skill mix with different types of health professionals and keeping nurses in the front line doing what only nurses can do. But I think it's a big challenge, Debbie. And I think for physio as well, Lindsay's got full support to recruit, but she's always dependent on those graduates. It's sort of almost like an annual thing for Lindsay.
Yeah, they're all gone to the community PSC, now we're going to have a massive opportunity in this, isn't there?
Yeah.
And all of the therapists now.
Yeah.
I don't think it. I think Lindsay knows what's going on.
I think there is. The thing is that Lindsay and I have talked about this, and we're desperately pushing for an integrated therapies approach to the Wirral. In fact, I was discussing it with Simon Gilby from the Chief Exec of the Community Trust yesterday, along with the Commissioner, and there's still a load of dancing around the handbags, if I'm honest about it. But I'm desperately pushing to say this can't continue. We need a much more integrated service, and it's madness at an NHS level to have people leaving one area to go and be recruited by another. Why can't we work as if the boundaries don't exist to try and do it? And I know that's something that Lindsay's been really keen on, but we're desperately trying to make sure that that happens. But these things take some time. Lindsay, is there anything you want to say?
No, I mean, I think the integrated therapy model, I think the thing again is about the over-recruitment, which, back in February, March and said,
we need to go out when the graduates are coming out, and unfortunately we haven't done, and that's why we are kind of in such a situation that we're in really. And I think we need to look at that with nurses, that it's the same model. You may need to over-recruit so that you've got people in post.
Absolutely. Because you know the people that have done it have been able to minimise the agency spend and other expensive resources. It's back to making sure that we have a...
And I have to say with Cerner, we can't use agency nurses because they won't be able to function, David.
Yeah.
But we do use FlexiBank, that's our main use. A lot of the local spend is around other professionals, it's not just the nursing.
Sure,
All
absolutely.
AHPs we have now.
Yeah. Anything else?
Do we know how much money is attached to the vaccination? Can we get the message out that sort of take a jab for the organisation by saying that we'll...
The difficulty is you can't
extrapolate
there isn't
it.
anything specific at the moment that says, you know, if you get 75% you get X.
Right.
It's that if there's often if there's money coming later in the year, there'll be a range of criteria. Often those criteria are, have you got 75% vaccination? Are you hitting A&E? Are you doing your RTT? So if you perform well, you can have some money.
It's a shame almost, because we could try and get everyone on board with the idea that
it's difficult, but
trying
as
to
you say,
engage
it's
the lower
part,
ranks
but
of the domestic
unfortunately there isn't a direct.
Yeah, and that's
it's
how it
about
usually
making
is.
sure if opportunistically money comes along, as Alistair says, then we need to have all the right things and the right things. But again, we know how challenging it is when colleagues aren't at work, and the pressure that it puts on the service and the colleagues who are at work. So again, having the flu vaccination is one of the things we can do to try and ensure that the majority of people remain at work, and we know that gives us the best possible service. Anything else? I know it is challenging, but there's no doubt when you take a step back and see each quarter what we're doing, and I know there are difficult circumstances, and Debbie's outlined some of these things, but again, what we do benchmarks very well against other people. We've heard about a really great example with the JIVE accreditation, but in many other areas, we just need to keep doing the right things, focus on the right quality, but undoubtedly we're going to have to do that at a cheaper cost if we're going to be able to be sustainable, and therefore how do we do that? And that's the really big challenge that we face. And I know it's challenging, but from what I can see, people are desperately trying to do a very good job, and thank you for that. Okay, thanks.